Hello everyone. Welcome to the integrated session for the NEET and NEXT. So today we are going to do the integration of ophthalmology with the community medicine, and me along with sir are here along with the NPCB program. I think this is going to play a very important role in the upcoming exams because they are giving more and more emphasis on the community medicine, and I'm trying to integrate ophthalmology with every subject, and I felt that
with
this
the
is the
community
need of the hour,
medicine
because
and
recently Vision 2020 is expired, and we have not met with the objectives. I think that was the worst part of Vision 2020 that went into COVID, and we could not obviously met the objectives, and all the eyes are on NPCB program now. So let's get started. Sir will be telling us something about NPCB program.
Thank you very much, ma'am. So as you all know, now we are not only focused on blindness, but we also have added visual impairment. We added it to cater for refractive error, because refractive error is the most common cause of low vision or visual impairment. And there are many new initiatives under this program, and there are changes in the cutoff, which we will also discuss in this session.
So sir, how are you people, working on this? How you instruct your, workers and all to get screened this refractive errors?
Like first thing is, if in a hospital they are doing the screening, then of course they say it by the Snellen chart, less than 3/60. But in the field, we say that try to measure, ask the patient to close one eye and then read the fingers from a distance of 6 meters. And then if the patient is not able to read it from 6 meters, then go to 3 meters and then ask the patient to read the finger from both the eye, one after another. And then if he cannot read from 3 meters the finger, then we test with a torch. Or nowadays we have our mobile
torch. Phones. I don't think that anybody is carrying torch nowadays.
No one is carrying. So
nobody
we ask
is carrying
the patient that from which side the torch light is coming. That will indicate whether the light perception is present or not.
So definitely after the session, sir, I would like to see that how you check the perception of light. And every time I take the class, I always tell them how to take the visual acuity, how to take the perception. Not because it is going to be asked in the vivas or they have to give the award leavings. I want them to know this because whatever knowledge you have of ophthalmology, that will be the end. If only you become ophthalmology resident, only then it will be propagated. And I want each of my students to know these things correctly, because obviously they play a very important role. Whenever you are sitting at a dispensary or a PHC or a CHC, everybody is going to expect that this much should be known to this doctor, everybody. So if you are an orthopedician, you are a surgeon, and
or a PSM person,
and if you do not know how to take a visual acuity, I think that will be not a very good thing. So that is my personal initiative. I always give a stress on this. Please show me how will you cover the eyes, how will you ask the fingers. Don't give them a order showing 1, then 2, then 3. These are the common sense, because person can obviously know that you are going in order. So you have to be very random. You have to close the eyes with the palm. Don't use your fingers because person can see through this. So these are very, very little things that will help you to measure the visual acuity very, very correctly. Okay, so let's talk about what is blindness actually. Yeah. So before going actually to the NPCB, the objectives, we should know what is actually blindness. So going by the definition of blindness, first of all, we'll talk about the WHO criteria. So I think everybody knows that WHO criteria says visual acuity less than 3/60 or its equivalent. Now, what do you mean by this equivalent? Now, every time you are sitting on a PHC or a CHC, so do you have the Snellen's chart there? No. So most of the people do not have the Snellen's chart. Now, sometimes I ask my colleagues, they say, "Ki we'll take out the printout." But do you have the printer there every time? You don't have the printer also.
You can have a printer at PHC.
Only
but at sub-center, again, you are
yeah.
without Snell and chart.
Yes. Yeah. So what will you do there? I cannot say just because I cannot take the visual acuity because I do not have a printer here. I cannot show it on the phone. So what are the things you can do? You can ask the person to count the fingers. Okay. So according to the old criteria, we used to have the counting of the fingers from 6 meters. Now we take it as 3 meters, right? Then older visual acuity according to NPCB was 6 by 60. Now we are taking as 3 by 60. So that was a very important update that came, that newer objective of NPCB according to the newer criteria that was taken in 2016. We have accepted the WHO definition, that is 3 by 60 only, and that too with the best corrected spectacle correction. So every time you have this confusion whether it is uncorrected or whether it is best corrected, you have to take the best corrected visual acuity. Even sir, if you people are sitting there and you want to see whether it's blindness or not, please always ask the person to wear the specs, and only after that you have to check it. Sure. If he is actually 6 by 18 with specs, I cannot say that he is blind. So that is again very, very important. And the third important thing is your field of vision. So with respect to the field of vision also, we can measure this visual acuity. It should be more than 20 degree. According to the newer criteria, it will be your 10 degree. So I'll repeat it now. It will be your counting fingers from 3 meters, visual acuity 3 by 60, or the field of vision to 10 degree. That will be your blindness. Now, one more important thing. Whenever you get the visual acuity, you always want to get it in the meters. We are comfortable in meters, but in US, we actually take it in feet. Now, you should have a way how to, get its equivalent in feet also, so that if you get a question in 20 by 20 terms, you do not feel awkward and uncomfortable how to deal with it. So there's a simple thing, how will you test and convert your visual acuity from the feet to meters. Suppose, let's take an example, you are given a visual acuity of 20 by 18 and 80, and you have to convert it into the meter one. So what you are going to do, you have to convert it into decimal. So 20 by 80 is your 1 by 4 and simply multiplied by 6 by 6, and it's there. You are there with the visual acuity in meters, that is 6 by 24. Now me as an ophthalmologist, I know what does 20 by 80 mean, what does 20 by 70 mean. But sorry sir, if you are sitting at your center, he may not be knowing that what does this 20 by 80 mean, and he want to know whether this person is blind or not. So simple thing sir, you can do, you can convert it into fraction and just multiply it by 6 by 6, and you get to know that it is 6 by 24, because so many people may be coming to you also to get their certificate signed. Sometimes people come that blindness with the blindness certificate, and we want to know what is their visual acuity, and maybe a person has come from US, and there the visual acuity which is monitored will be your 20 by 80. So what you cannot say that I do not know whether it is following the Indian criteria or not. So simple thing, convert it into the fraction and multiply it by 6 by 6.
That was a new information for me also.
I think this is a practical one, because these people may not be knowing this. They have to deal with the hundreds of other things. So it's a simple thing, and you can even pass on to this this information to your juniors also, all those who are sitting there, that they can easily convert this into the visual acuity in meters. So let's talk about the types of blindness. So you all must be knowing, I think sir must also be telling you about this. And actually we were discussing that he used to tell a very interesting mnemonic. What was that, sir?
Choti ma.
Choti ma, less ma. Okay. So what was this less ma? Okay, let's talk about that.
So when previously we used to define this cutoff according to NPCB, we used to say that there is this 5 thing. One is low vision, which is of course less than 6 by 18. Then economical blindness, which is 6 by 6. This is older one which we use, 6 by 60. Then social is when it is less than 3 by 60. Then manifest blindness when it is less than 1 by 60. But yes, here the light perception is present, and it is absolute when there is no light perception.
Yes.
So this was the older one, which we used to remember by the mnemonic LESMA. Okay.
Yes.
Now, what is the newer changes, newer cutoff that they have used? Again, it's very simple to remember. This is the table. This is the table which is telling you about the cutoff. I think
it's very
not
recent.
So common. Yeah, it's
very recent, and I think books does not give this, and that is why also this is also one of the reasons that we came up with this topic in the live, because many a times updates are being asked in the exams. So we'll tell you the source also, like we have downloaded it, and you people can also download it and see
directly from NPCB VI government guidelines.
Yes, from that website we have taken it this. So you can go through it, because earlier we used to have the same one only. Even in my classes in community ophthalmology, I used to tell the same, and though I used to say that this is very vague, I do not get what is economic blindness, social blindness, manifest blindness. Blindness is blindness. So now they are using, I think, more kind of those words which are making sense. Mild, moderate, severe, it's okay, but that was a little vague, economic, social, manifest. So yes sir, tell us about this. What are the new things they are going to say about it?
Yeah, it's very simple to remember. When we start with the mild thing, this mild is also known as early.
Okay.
So early or mild visual impairment means less than 6/12. That is mild or early.
Less than 6/12.
6/12.
Okay.
To 6/18. Okay, so less than 6/12 is mild. Then we have moderate, and remember, moderate is the one which we call as low vision.
Yes.
Now, so low vision start from moderate.
So what was low vision before is moderate now.
Is moderate.
Yes.
Now. Very
okay.
good, ma'am.
Yes.
So it's less than 6/18, and it goes till 6/60. So this is mild is 6/12 to 6/18. This is moderate. Then we have severe. Severe means less than 6/60.
Okay.
To 3/60. And when it is less than 3/60, then it becomes the blindness.
So that means the same definition, blindness, has come again to 3/60 only, and just instead of the words economic, social and manifest, which were not so relevant, they have just converted into mild, moderate and severe. So not a problem, you can easily absorb it. What was your economic, social, manifest blindness? It has come to mild, moderate and severe. Yeah. And the blindness criteria with a little, not exactly the same, but it is somewhere around that only, and your basic definition of blindness is also remaining same. Yes.
So this is the table. Again, you can see the same thing here also.
Yes. So starting with the blindness, it is less than 3/60. Then we are having severe. Severe is from 6/60 to 3/60. Then you have got the moderate, that is your 6/18 to 6/60, and early is just 6/12 to 6/18.
And early is same as mild.
Early is same as mild. Okay. Then we have got something which is your visual impairment as well as the functional low vision. So what do you want to say in this? Visual impairment.
Same, visual impairment or low vision, as I was saying, the cutoff was same as previous. It is less than 6/18.
Yes, so we used to take the same 6/6 to 6/18 was your normal vision, and from 6/18 to 6/60 was the low vision. But now they have not given this particular thing that it is from 6/18 to 6/60. But I think for all practical purposes, it is the same. Your visual impairment is your low vision, that is your 6/18 to 6/60. Then there is something which they are saying functional low vision. So what is this functional low vision?
Again, they are taking the cutoff of less than 6/18 and they are taking it to light perception present, 6/18 to light perception present.
Yes.
Okay? And then they are asking, saying that the visual field should be less than 10 degree, as ma'am has discussed that it is the definition of blindness also, that the visual field less than 10 degree. So they have used it, and then they say that for the blindness, we take the best corrected visual acuity and we take it by pinhole test. So the pinhole test result or the best corrected visual acuity should be less than 3/60.
So I will, because they are mentioning pinholes, I'll talk about pinhole. I think my students know already what is pinhole. We have got a circular kind of occluder which has a very small hole in the center. So that pinhole, so whenever the person, reads less, the visual acuity is not normal, we are giving this pinhole. So sometimes we have got a handle also, or we can give this in the trial frame also. So if the person is reading through that pinhole and there is improvement, that shows that the patient was having refractive error. So that is a very, I can say a quick thing. With the help of that pinhole, even we can keep that simple instrument at your centers and we ask the person to read through it. And sometimes what we do, if you do not have that sophisticated pinhole, you can use even a cardboard, sir. So anything that is available at a hand, take a cardboard, give a small pinhole in the center and ask the person to read. So within seconds, you'll get to know that this person has a refractive error and you can refer this person to the higher centers, to the ophthalmology. Now suppose this person is not having even that vision after this pinhole. So it is worsening. So that shows the person has some macular pathology. And if there is no improvement, that means there is some disease, organic pathology. So I think a beautiful example of a simple instrument with the help of which you are able to get so many things and you do not need even that sophisticated instrument everywhere. Just take a piece of cardboard and do a pinhole there and you are there with it. So I think this is a very good thing. Yeah. All right. Now, as we were discussing also that the priority list, because whenever we are coming at the level of fields, we have to work, it comes to priority. So whatever is our load, we have to actually prioritize those. So there is a slight difference between the priority list of the WHO and the NPCB visual impairment plan. So what you are going to say about this?
Yeah, it's very simple to remember. The first 4 diseases almost same in WHO and India list. That is, of course, cataract,
yes,
refractive error, then childhood blindness and trachoma. That is same. But because in India, trachoma mostly occur in upper eyelid, so we are in Indian list, we have focal trachoma and not trachoma. That's the only minor difference. But all the first 4 are same.
And I hope you people know what is focal trachoma. Focal trachoma?
I just know that it is something which involves the upper eyelid, so it is they are calling focal.
Okay.
Correct me if I am wrong.
Yes. So focal trachoma means all the part of the eye is not involved. Otherwise, it involves the conjunctiva also, cornea also. We have so many sequelae in the eye, this eyelids. Every part is involved. So only if it is limited to just one part, it could be eyelids, it could be conjunctiva, it could be any one part, then it is focal, not the diffuse, right?
And of course, the 5th disease in WHO list is onchocerciasis. And I just came to know today only that I was pronouncing it wrong as onchocercosis. Ma'am corrected me there. And then we have 3 more diseases in India list. One is diabetic retinopathy in adult and retinopathy of prematurity in children. Then the 6th one is glaucoma and the 7th one is corneal opacity. Okay, so India, is way ahead of the world. So we have included 3 additional diseases here. In fact, you can say 2 additional diseases, glaucoma and corneal opacity.
Yes.
And we have replaced onchocercosis with the diabetic.
So luckily we do not have the river blindness here, but we have got so many other things. So instead of that, we are working for the diabetic retinopathy in adults. We are working for retinopathy of prematurity in the children. And in the lower terms, we are also talking about glaucoma because, glaucoma, it's not that common as cataract, but it is irreversible. So in that way, I think glaucoma should be given enough importance because all that vision loss which occurs due to the glaucoma is totally irreversible. And because cataract is much more common, so every time like people are talking about motiabind, I think at your areas also, rural population, everybody knows what is motiabind, and even they are getting corrected this motiabind because they say that we can have a kala pani glaucoma. So we are trying now to start a awareness that even glaucoma is notorious, which runs in the families, and don't think only of the cataract. Okay, glaucoma is also important, and nowadays even they say that the corneal opacity is taking a head over the refractive errors. So though it has not come up in the data as such in the books, maybe in the next year or the coming years they are saying, because at some places we have read that corneal opacity cases are increasing, and that may be due to trachoma itself. Trachoma is in itself is responsible. If you remember the Fisto classification, sir, I think Fisto classification WHO has given, and
I forget it.
okay, so the Fisto, sir, let us tell sir. Fisto, F for follicular, I for intense inflammation, okay, T for tracheasis, that is your lid deformity, okay. S for your scarring, T for tracheasis, and O for opacity. So this O of the Fisto stands for opacity of the cornea. So I think students as well as sir will now remember, it's very, very important, the Fisto classification of trachoma. So trachoma itself can also lead to the opacity of cornea, and I think that is why the opacity of cornea is going ahead, because we can have the congenital cloudy corneas, that is important in cases of children. There also we can have the opacity. Then we can have corneal ulcers also, that can also lead to corneal opacity. Then we can have the allergic keratoconjunctivitis, that can also cause corneal opacity, and trachoma itself. So we have got so many infections, even viral keratitis, herpes, that can also cause corneal opacity. We talked about corneal transplantation. There I told you herpes simplex keratitis, that can cause corneal opacity. So corneal opacity is taking a head over the refractive errors, okay, vis-a-vis that it can also cause a huge amount of bulk of blindness.
I remember follicle, but I
intense inflammation.
Intense inflammation.
Yes.
Then S is scarring. T for tracheasis.
Don't worry, we will keep on asking, yeah?
We will keep on. And then O is for opacity.
So, without wasting much time, we are coming on the objectives of NPCB program. Now, though, you know, objectives does not mean that it is actually happening, but it is very good to make the right objectives. If you do not have the right objectives, obviously you do not have the path to follow. So, let us start with the signature activities. So, let us ask sir, he will be explaining what are the objectives of the NPCB program. Sir, let's start with the cataract surgeries. Yeah. So, how do you plan at your field? How many cataract surgeries are you sending to us?
Yeah, they say in the guideline that at least 300 cataract surgeries should be done per 1 lakh population. That's the minimum cataract surgery.
Look at the guidelines. They themselves are saying only 300 per lakh. Okay, lakh look at this. So we need more and more ophthalmologists now.
Very, very much needed.
Yes.
And they say that they are doing this 50,000 donated eye keratoplasty, and they want to continue it as their first objective. Okay, but in reality, it is only 25,000 donated eye per year. But anyway, we always say objective much bigger than what we can, and so we plan that.
Yes.
Now, second is to reduce the backlog of avoidable blindness. How we are reducing the backlog? That's what they say, that at least 300 cataract surgery per 1 lakh population.
What is avoidable blindness?
Avoidable blindness is like if we detect it early, before it causes blindness. Then
avoidable blindness consists of two things. One is your preventable blindness and another is curable blindness. Okay. Preventable, like trachoma, it's an infection, we can prevent it. We can take the safe strategy, right? And we can prevent it. While curable means like cataract. We cannot prevent the cataract, but it is totally 100% curable by surgery. So, in the avoidable blindness, both of them are included. Both preventable as well as curable. Total makes your backlog. So, whatever are those diseases, see, there are certain diseases which we cannot help. But there are certain diseases which we can help. Either I can prevent it or I can cure it. So, my objective is leave that 50% that I cannot do anything. But at least grasp that 50% where I can do everything. Either I can prevent it or I can treat it. And that is the reason we are often now, we are doing the camps of the cataract, because I can treat it at a 100% one. Alright?
Yes, ma'am. One more thing, very debatable, that the government said that we should not do cataract surgery in the camp, because next day there will be no one to do the follow-up. So, and of course the infection rate will be comparatively higher than if we are doing it in an institution. But again, when we go on the ground, the reality is that cataract surgery is something which many a time is, because district collector is the head of NPCB VI program at district level. So district collector organize it in a way of camp, but it should only be done if there is fixed facility like a hospital or something. So I think ma'am is also saying the same thing, that when ma'am said camp, she also mean that camp in a fixed facility.
Yes, camps with the minimum, desirable facilities should be there. Any surgery, be it any surgery, this is a cataract surgery, you cannot do without those basic bare minimum requirements, and especially in the eye, you cannot take risk. Infection means eye is finished. So I always say end of ophthalmitis is end of the eye. So it is end. So you have to always take care, and this is one major barrier that we have, that we face in doing the cataract surgeries in the camps. Otherwise, I think it's a very good initiative, because you are not able to bring the people to the institutions. You are going there, you are relieving their apprehension. So many times they have apprehension coming to the cities, they don't want to visit the major cities, big cities. We people live in NCR, you don't know, actually people have a fear of coming out of their places. They don't want to talk to those people. So that is why we have those Anganwadi workers, we have got local people talking to them, so that they can relay their anxiety and make them comfortable. They can come up, they can talk to them, and they can even get operated, right?
One of the major cause of anxiety is the expenses that they will have in the city.
Sir, we have got free services also available, government services available.
That's why it's very good if we are going in the village.
Yes.
Then we are helping them in lowering their expenses as well.
And the thing is that they don't have the proper knowledge. Like everything is free at Guru Nanak Eye Center. MEMC, a very good center indeed. And I myself was there in the investigation lab. We were doing ultrasound, CT scan, all the things just free of cost. But the thing is that people don't know. So a right guidance is actually also very much required. Then moving on to the next one, sir.
Yeah, we have comprehensive universal eye care services. That means what ma'am was saying, we try to make this eye care services available to rural population, also tribal population also. And
we have to try to make them universal. It should be same for all. So if you are giving 100% at one place and 0% at one place, my benefit will be very, very limited. So what is our initiative, that at least give 50% to all then, so that bare minimum basic standards are actually met for all. So quality services and uniform distribution. So for that, what we are trying to do for the uniform distribution,
we are strengthening the infrastructure facility.
Yes.
We are creating more good ophthalmologists who will work at probably for the people in government hospitals. So, like ma'am is doing.
I fear I won't be able to work at the sub centers, and it is sir has to go there, and we have to upgrade. We can work there, but obviously we all require a chain. Nobody can work at all the levels. So teamwork will always win, and we have to actually strengthen the infrastructure that is also always present. See, if you study in this story kind of a thing and you relate it to the real things, it will not be a burden for you to learn extra. You will just see the session and you are done with the NPCB program. Now you are confident. Any question asked about NPCB, I have seen that episode, I know everything. So the purpose of these short episodes is so that you can just see it and you are done with the topic. Not that you go and write it in your notes, and don't send me the message, ma'am, should we note it in the notes, or we should learn it from there. Just see this episode and you are done. So that is, that will cater your, freshen up your mood also and make you ready with one more topic. So what you are doing, you are upgrading your regional institutes of ophthalmology, so that when you require the facilities par excellence, you are there. Plus, you also have to keep on providing all the eye care facilities in the districts also. Everybody cannot come to the AIMS center. So, I am giving you the apex of the pyramid. The best center is available, and it's available for all. Anyone and each one is free to go there. But can it go to every place? No. So that is why we are creating more and more aims. I agree, the aims which are there in the periphery may not be that good at today's point, but in the time to come, they will be upgrading and upgrading, but at least they are available. That aims which is available in Delhi may not be approachable to everyone, but these aims which are in the periphery, at least they are giving the standard services to every person. What else? I think this we require from you.
Yeah, we have the three usual thing which is mostly an objective of any program.
Yes.
Community awareness, expand the research, and involve private NGOs to have better implementation at ground level or at peripheral level. So the three is the remaining three: community awareness, more research, and increase private participation.
So yes, so I think these things are actually, and they are mandatory for the success of any program. If the community awareness is not there, no matter how good you are doing, they are not going to participate. So your ultimate goal will fail. If you are not increasing and expanding the research related to it, if you are not getting the scope, how you can improve it, you are not going to benefit. And participation is very much required, because as a one person, I cannot introduce these facilities for all. So I will require the private practitioners, I will require the local people also, I will require some voluntary organizations, some clubs. Rotary Club, I think, is very good in participating that. So and we have volunteers actually. I have seen people who are very, very, active. They want to work, but they do not get the right initiative. So it is our responsibility to find out those people who are really interested in working, who are volunteering, and they want to give their services for the mankind. Everybody will not be ready, but there are so many people who are ready, and you will have to reach to them. That is very, very important. So now I think sir will tell you about the organizational structure for NPCB. So if you are expecting a particular structure in NPCB, what are the levels we are going to have, and how they are going to coordinate at different levels, that is your primary level, secondary level, and the tertiary levels. Yes.
So there are two things which is very worth noticing. First thing is that we say it is primary level, but it is not at PHC. Primary level is also present at CHC, that is sub-district hospital, because under one district hospital we have at least around 5 to 6 CHC, and one CHC is at a block level over 100 village. So primary level do not only involve PHC, but it also involves CHC. Okay, so primary level have PHC and CHC. Then secondary level will have district hospital, and tertiary level will have the regional institute of ophthalmology and center of excellence, like the usual thing. That's the tertiary. Tertiary means medical colleges. So tertiary is same, secondary is district, primary is PHC and CHC. And then after that, of course, our I program come under Ministry of Health and Family Welfare, and it is 100% centrally sponsored program. That's what they write in PARC also, latest edition. So remember, it is under Ministry of Health and Family Welfare. Then under state, we have state ophthalmic cell, and then we have district blindness control society at district level. So central is health and family welfare, then state, district. And if we say tertiary, secondary, and primary, you will remember that primary means PHC, CHC, secondary is district, and tertiary is the regional institute of ophthalmology. Okay, so this is the organizational structure.
Yes, so I think this is a good way, and you should definitely know this, because if you know the outer structure, it will again become easy for you to solve any question related to it also, and also to understand the proper functioning of this NPCB program. You should know how the center, state, as well as the districts are interconnected. Now we'll talk about the activities. What are the activities that we are going to have under the NPCB program? So as sir has already told you that the most important priority list consisted of the cataract. So obviously we are going to have the cataract operations. Then it's very important that you involve the NGOs, because let us accept this bare truth, without the NGOs, without the cooperation of the other people, you are not going to have. So if you are doing it alone, your program is not going to run a long way. So in order to go a long way, you have to take the help of the private practitioners, non-government organizations, your voluntary organizations, all these things you have to take care. Then your IEC activities, that is your information, education and communication, those activities you have to take. Then the information system. Now obviously you will have to pass on the information, you have to intercommunicate. If you are working at that large level, the communication is very, very important. If I do not know what is your next step, I will coordinate with the other people. So that information, I think for doing any of the activity at a large level, information and the communication system should be very, very strong. And you know, the eye health starts from the school itself. That is a very, very important thing. And school screening systems, from the time where we have improved the school screening programs, I think children have gained lot in terms of their eye health, because we have even taught the school teachers to screen these students. Yeah. So we as ophthalmologists cannot reach everywhere. So what we have done, we have given them a panel of doctors where they are having a physician, they are having a pediatrician, they are having a dentist, and even this ophthalmologist. So the ophthalmologist will be on call 24/7, they will be there. Then on the prior given dates, they are going to, you know, visit these schools also, and on the other days they can actually go on monitoring, and whenever they find that there is a gross abnormality and a student is not able to read properly, then they can always send those students to us. So I think we are able to pick up the refractive errors from a very early stage, so that amblyopia is neglected, and even they will be having the better eye health in their adulthood also. So this is a very, very good initiative. Then we have to do the collection and utilization of the donated eyes. This we have talked about in a great detail in our other integrated videos, that is your corneal transplantation. Then a very important thing is your control of vitamin A deficiency, because of course vitamin A deficiency is one of the important causes of blindness in children. I think this and this is covered, I think, at both places. Vitamin A deficiency, that whole of your classification, then how much we are giving, the doses, and when does you give the this vitamin A, everything is covered already. Okay, that is again important. And finally the monitoring and evaluation. Whatever you are doing, you have to assess. Like when you are giving the GT, you have to assess. Similarly, when we are doing this activities, you have to assess. So for that, you have to monitor.
Yeah, and I would like to add 2 points over here. In the one thing is that this school eye screening program which we are talking here, it comes under Vision Center.
Yes.
Because right now we will also discuss the VSTC, Vision Service Training and Center of Excellence. So it is the most basic is the Vision Center, which should be of course 20,000, and it is at PHC level, where we do not do any cataract surgery, we only do the screening. So school eye screening program come under Vision Center. Second point is, of course, you know that the total dose of vitamin A that we give is 17 lakh, and a mother has to take her child for 9 visits to complete this dose. So total dose is 17 lakh. Of course, you I think know that after 1 year we give 2 lakh international unit every 6 months, and below 1 year we give 1 lakh international unit only at 9 months. So yes, total will be 17 lakh by 9 visit. So these are the things that we are doing under NPCB.
But sir, I think many of the babies who are coming to you maybe more than 1 year, but you know, PEM is a very important and common thing. So they may not be meeting that minimum requirement of 8 kgs. Yes. So if they are more than 1 year, but they are less than 8 kg, you have to follow your 1 year regime only. Okay. They have to be given only 1 lakh international units. Sure. So I think if you are people are giving vitamin A there, because you know, even for the basic vaccination, universal vaccination, they are going for the this dispensaries also, PHCs also, and you find that you have to give this vitamin A along with the vaccination and the child. So please take the weight of the child. If the weight is less than 8 kg, and if I give 2 lakhs, that will certainly cause the vitamin A toxicity. So it's a fat soluble vitamin. So that is very, very important that you do not give the overdosage of vitamin A. Okay. So I think that was a very fruitful and worthwhile discussion about NPCB, and I think it was quite entertaining, जो कि हमेशा होता है Dr. Ashwini के साथ. So people always say that he tickles the funny bone. So yeah. So now without wasting much time, we will be dealing with the new initiatives. I think I was very tired when we started the session, and now I'm feeling quite refreshing. So this is the amazing quality of him.
It's because I think you like to give information. Like when you are giving information, you are totally energetic and all.
Okay.
I think you are like
so
helping a student. That's why you are.
okay. So he's quite moderate.
Yeah.
Okay. Modesty is in fashion. So, okay, so we'll be talking about the new initiatives of the program, because we are quite hopeful about this. We do not have Now Vision 2020 anymore. So, let's see what they are bringing, the new ones. So, what are the new initiatives in our 12th 5-year program? The distribution of the free spectacles. I think this is long awaited, and every time, you know, they are asking us to give the free spectacles. Time and again, we create the camps also. So this is a basic requirement of your 12th 5-year plan, that distribution of the free spectacles for the near works to all those old persons who are having the presbyopia, and a telemedicine. So sir, how are you planning for this telemedicine? I think we as ophthalmologists are going to get absolutely new kind of work. Telemedicine and ophthalmology department, and now I will have to remove that slash from my WhatsApp, because earlier I used to say that please don't show your patients on WhatsApp and video call. This is not for the academic purpose. This is not for clinical purpose. It is only for talking to your relatives. But now telemedicine is coming. So I hope these people will be doing now video calls to us. And I don't know how will I apply the slit lamp over that phone and visualize them. But of course, jokes apart, it will help. At least, you know, whatever things could be seen, and instead of audio calls, just you know, guessing what they have, we can have a glimpse of the patient. We can see the matting of eyelids, you can see the type of discharge, you can see trichiasis, entropion, ectropion, corneal opacity. So there is, and we can also guide Dr. Ashwini, please avert the eyelid, and maybe he learns how to use the you know, earbud and do the aversion of the upper eyelid, and we'll be creating more and more new ophthalmologists at the fields now. So there will be, you know, telemedicine in the ophthalmology department. Let us see how it works.
I was just joking before that the days are not far when we will even do palpation by telemedicine.
Yes, anything is possible. Anything is possible now.
I think telemedicine is a good initiative, but one problem is that when there is telemedicine, then the need to increase the number of ophthalmologists and the force which is being given to make them available at the peripheral center decreases, because now people think we have alternative, so we need not to send ophthalmologist at peripheral area. So it's a good thing, but at the same time we should always try to have more doctor in peripheral area, more ophthalmologists, because again we all know that field worker, they cannot do the procedure of turning eyelids and all, and we will not be available, like even PSM person will not be there. So I think telemedicine is a good thing, but at the same time we should try to make real ophthalmologists available.
So please sir, keep all the, you know, instruments and diagnostic services ready, because we won't be able to bring the slit lamp along with us. So keep those things ready, and certainly we will be there at the back and forth call. And then the other thing is that you will have to provide the multipurpose district mobile ophthalmic units in all the districts over the country. So, you know, every time ophthalmologists, as I was saying, will not be available there, but in the mobile units we can go, and I think that could be a vanity van kind of a thing, where we have got those portable slit lamps, some tonometers, some basic kind of stuff is there. Obviously, if there is a, you know, a grave situation, then they will have to come over. But like I think this Dr. Arvind Kejriwal also started with this mobile, you know, units, mobile OPDs were there. So that same kind of a initiative, ophthalmology units, we are, let us accept this fact that that was a good initiative what he started. We were having a mobile OPDs, and that helped a lot of people. Okay, nothing to be personal about it. And similar kind of multi-purpose multi-purpose district mobile ophthalmic units we can have. Like we are going for the corneal, corneal transplantation also. Now we are bringing the specimen. So same kind of thing could be there with a more of some units. Especially if you talk, then we have slit lamp is very much required. We are not able to see the different layers and all with the help of the torchlight examination or the ophthalmoscopic examination. And certainly I think when this happens, we will be able to help more and more of the mankind with our ophthalmic services.
Yeah.
So I think we have come up to the end of the session, and
we can just have a quick look on that, the way we can have a quick look at the Vision 2020, which was the older one. But we just quickly, I just want to tell you the things that these are the 4 things which we have. VSTC, just like the Mumbai buses are VSTC, so we have the VSTC here. It's V for vision, S for service, then we have training center and center of excellence. I think you know, and we start with 20,000, then we go to 10 less in every year, and like there will be 20 center of excellence and 200 training center, 2,000 service center, and we will doing the cataract surgeries at service center and training center and center of excellence, but no cataract surgery is done at primary level, because that will work only for screening, and the school eye health program will also work under vision center, which is primary level vision center. So I think we should quickly go through it, although it has expired, but we can.
All right. So I think this session has come up to its end. I hope you people have enjoyed this session, and you people have also enjoyed the new integrated art of learning that we are trying to incorporate, because not only next will be coming, but even the NEET PG 2021 will definitely have integrated questions, and we at DBMCI are already into it, and we are teaching by far the students in the integrated way. Now you do not have the weightage of the subjects, because every of the question will be having 2 to 3 subjects incorporated to it. So you cannot really dissect out. Suppose the question comes on NPCB only, then we cannot say that whether it has come up from the community medicine or it has come from ophthalmology. So you should know the subject as a whole, you should know the topic as a whole, and this is the initiative that we have taken to tell you the clinical approach, how to approach such kind of questions and come up with the flying colors. So do tell us in the comment section how did you like the video, and also do tell us what are the other topics that you want us to come up, so that it help you in the last minute revision, edge over the others, so that you feel comfortable in solving these clinical kind of questions. Do like the video, do subscribe to the channel, so that we are motivated in making more such videos. Thank you.
Thank you everyone, and thank you ma'am. I learned some really new things today also.
Oh, thank you sir, thank you. Thanks a lot.
Thank you.